Good morning, this is Dr. Joe Moscato, and today we're going to talk about oncologic emergencies. And we have several to talk about today, and we rely on you nurses to help us in this regard and to be observant for these on the floor and let us know, as they can occur sometimes quite abruptly. First is tumor lysis syndrome. And this refers to the overproduction of uric acid, potassium, and phosphate from the rapid destruction of tumor cells. Risk factors include a high LDH, high-grade lymphomas and acute leukemias, but it can also be seen in any rapidly growing cancer, such as small cell carcinoma. This can result in acute renal failure, severe hypocalcemia, hyperkalemia, and arrhythmias, and can be fatal. So we always want to try to treat this and avoid it if possible. Now, prevention of tumor lysis syndrome, and you'll see us do this, is the use of allopurinol routinely to try to block the production of uric acid, hydration, and occasionally, if somebody presents with a very high uric acid, rasburicase. The role of alkalinization of the urine is somewhat questionable, but generally doesn't need to be past 6.5 to 7. Remember, the purpose here is different from that of excreting methotrexate, where you also see us use alkalinization and high urine outputs. Watch for phosphates of greater than 4.5, uric acids of greater than 8, potassium greater than 6, or calciums less than 7. And if you see those labs coming back, you need to let us know if we haven't seen them. The next problem is spinal cord compression. And interestingly, there's an average delay of 10 days at home to diagnosis after symptoms begin. At least half of the patients are non-ambulatory before the diagnosis is made, and most of these, unfortunately, will never walk again, so rapid diagnosis is possible. I have tragically seen this occur on inpatients, and no one notices it, as nobody got the patient up to walk. So it's important to be cautious for this. The thoracic spine is the most common site. And the most common cancers are lung, prostate, and breast cancer, but any cancer can cause it. Multiple myeloma is another common cause in our experience. Now, the symptoms are usually back pain, and almost all of these occur in the setting of back pain, usually increasing, sometimes worse lying down. And lower extremity weakness is the hallmark. There can be radicular pain and pain with coughing. Bladder or bowel weakness are late signs. And sensory changes can be mild and occur later than motor changes, especially if the compression is coming from the anterior cord, which it usually is. Now, the treatment is high-dose steroids, and anywhere between 20 and 100 milligrams of dexamethasone is given acutely. And the neurosurgical consultation is helpful because there are data that early surgery may help, especially if it's a localized area and especially if we don't have a diagnosis. We may give emergency radiation therapy, but if it's small cell carcinoma of the lung or lymphoma, we may move right to chemotherapy as it can rapidly shrink the tumor. The next problem we're going to talk about is pericardial tamponade. Now, this refers to the accumulation of fluid in the pericardial space with pressure on the ventricles and decreased filling. Symptoms and signs are dyspnea, elevated neck veins, hypotension, and a thing called pulsus paradoxicus, where when one is taking a blood pressure, one hears the normal disappearance as the blood pressure is lowered from systolic to diastolic expand to more than 10 millimeters of mercury. Now, unfortunately, with automated blood pressure machines, you may not see that. You usually have to listen for it. It can be acute and rapidly life-threatening, or subacute, but still critical. As we noted, the diagnosis is often made by a pulsus paradoxicus of greater than 20. An emergency echocardiogram is helpful, and an urgency of pericardiocentesis for treatment, usually by a cardiologist in the cath lab during a code. We may see it done in the room. We'd like not to get to that point. And the improvement can often be quite dramatic once drained. The next problem is SVC syndrome, or superior vena cava syndrome. And this refers to the compression of the superior vena cava by cancer or nodes, often associated with clot in the vena cava, which may therefore come on acutely. Its diagnosis is usually marked by a clinical picture of a swollen face, plethora, feeling of being on my head or standing on her head, and collateral veins in the chest or capital do so, although that takes time, of course. The CT scan shows compression of the SVC. The treatment is to elevate the head to drain, diagnose the cancer, emergency radiation or other treatment, and on very rare occasions SVC stents, although those are very rarely used and not necessary for the most part. The disease is somewhat self-correcting because collateral veins do occur, and so the head is able to drain. Surgery can be difficult or impossible if the patient can't lie down, which is obviously very critical if we don't have a diagnosis. And even the CT scan may be impossible, although the patient can usually lie down for a short time. Oftentimes a biopsy is obtained and the patient is treated with radiation quite acutely even before we have an answer, as long as we know we're going to. The next problem is hypercalcemia. Now the symptoms of hypercalcemia are confusion, constipation, pain, polyuria, and volume depletion, and it can be due to a PTH-related hormone from cancer or widespread bony metastases. The level of calcium which leads to symptoms varies from person to person and is more closely related to the ionized rather than the total calcium, although it still varies quite a bit. The treatment is normal saline, initially at 150 to 200 milliliters an hour and then decreased. Note that most patients are volume depleted at the presentation anyway. Steroids are useful for steroid-responsive cancers such as myeloma or sarcoidosis. Bisphosphonates are given such as Zometa or Iridia. And one can use furosemide, but one has to keep the urine output up and the volume up, so that you have to be cautious with that. The next problem is bowel obstruction, eventually seen in 40% of women with ovarian cancer, 20% of patients with colorectal cancer. The diagnosis is made with an obstruction series or a CT scan. We realize that x-rays can mislead and the patients may be obstructed without clear evidence on the CT or the x-ray, and it may just show ileus. Management is with an NG tube. Long intestinal tubes are no longer used, or no better than NG tubes. NPO, IV hydration, perhaps TPN, and of course the question then becomes surgery. Now, the surgeons will often come and see these patients, but they're going to be reluctant to operate unless there's a clear-cut demarcation at the site of obstruction, especially if we know the patient has an intra-abdominal recurrence. We may certainly be reluctant to operate. But if we don't know the patient has intra-abdominal tumor, or it may simply be adhesions, then surgery is often indicated. However, we'll often treat the patient with NG suction for a while and see if this patient decompresses before taking the patient to surgery. If we knew the patient, on the other hand, preoperatively had ascites or obvious carcinomatosis, surgery is often unsuccessful and may shorten life, so one has to be quite cautious. Ureteral obstruction is common in cancer, but usually unilateral, may only cause pain. Obviously, if the patient has only one functioning kidney, then this will cause acute renal failure and obviously is more urgent. The diagnosis is made by renal ultrasound. CT scan may be needed to find the cause of the obstruction, and the treatment is generally stenting via the bladder. If that fails, may need percutaneous nephrostomies, and later, hopefully, the radiologist can internalize these. So, in general, for oncologic emergencies, be alert. Note that the patients can deteriorate right in front of you, especially with spinal cord compression. Remember that you as a nurse can save lives and improve the course of illness. And communicate findings clearly by understanding these various oncologic emergencies. Thank you very much.